We'll talk a little bit about current situation and why we need to save D negative stock. What are the national guidances available to support this initiative? We'll talk a little bit about pre-implementation work, audits we've done, then the implementation phase and results, and then also what we can do to improve this initiative in the future. So a little bit about background. So as you can see from an HSBT infographic, the overall use of the red cells has been falling, and it has reduced significantly around 20% in last 15 years. And this is due to various reasons, including improvement of the surgical techniques, using of cell salvage, implementation of patient blood management initiatives as a single unit transfusion, etc. Surgical techniques improved significantly in the last 20 years and reduced requirements for blood transfusion in these patients. From our own example, when we went to pre-Amber Alert in October 2022, we were doing an audit because we didn't want to postpone elective surgery. So we were looking at use of surgical blood, and we actually find out, I don't have exact numbers, but we hardly any transfuse any surgical patients. So I don't know if anyone has the same experience. Also, better management of pre-op anemia and use of IV iron, as we could hear today as well, contributed to overall reduction in red cell transfusion. But despite this overall use of red cells is decreasing, there is increasing reliance on D negative red cells, and demand is constantly rising. So we all need to work together to make sure we have available supply of our D negative red cells for those patients who need it. So why do we need to preserve OD negative red cells? So as I mentioned already, we are over relying on the use of OD negative blood. NHSBT are working hard on strengthening of the blood supply, but we are still currently in pre-amber alert status for red cells or platelets. And I'm not sure if there is someone in this group who is unfamiliar with what pre-amber means. Actually means that there may have been reduced availability of blood for short or prolonged period of time. NHSBT aims to maintain at least 6 days of stock for the red cells. And I picked this report last Friday when I was completing the presentation, and most of the red cells sort of almost match 6% or even sometimes exceed, but O D negative red cells are constantly below this target. And then we know that we have some patients who don't have any other safe choice. They only must receive O negative red cells. And then I feel like we all need to conserve this stock supply for them to be available when they need it. So we'll look a little bit in the evidence, what is behind, because we all like to make sure that we are doing the right thing, isn't it? So it has been a lot of research happening last 15 years, and a lot of paper has been published around this topic. The research mostly looking at alloimmunization, because that's one of the risks involved with transfusion of D positive red cells to patient with unknown blood group or the patient whose blood group is D negative. And then also we're looking at the other risks. So what the research found, from what I could see when I was doing my research, is that the using of D positive red cells in D negative patients is generally considered to be safe practice. Risk of alloimmunization is variable, and it varies from about 21 to 26% in the patients who are D negative and receive at least one D positive red cells in the massive hemorrhage setting, and then it falls down to 3 to 6% for patients with unknown blood group who receive D positive red cells in emergency. The risk of acute hemolytic reaction after receipt of D incompatible red cells is less than 1% and is generally usually quite mild. Unlike acute hemolytic reaction caused by ABO incompatibility, anti-D causes extravascular hemolysis, which is usually not associated with severe complication. And lastly, in addition, for people who are alloimmunized with anti-D, this might not be a clinical issue because majority of the patients only experience single lifetime transfusion as an emergency. So I wanted to look a little bit what are the indications for use of blood group O red cells? When do we need to transfuse O red cells? So it's in major hemorrhage situation if we don't know patient blood group, for a patient who might have a previous blood group but they don't have a valid group and screen sample, if we have only one group and screen results available, and then for non-group O patients if their group specific blood is not available. Then also we have other clinical conditions other than bleeding where we might need to transfuse O red cells. This could be because there is discrepancy between current and historical blood group. Patient might be undergoing ABO incompatible stem cell transplant. There could be mixed field ABO reaction and we have no previous group, so we are not able to confirm exact blood group of the patient. We need to give O in the rare occasions of, but not rare, blood stock shortage, but I mean other blood groups. And then also for patients who might have complex serology or they might have a complex phenotypic requirement. So when I was putting this list together, I was looking, oh, there's so many reasons why we transfuse O red cells. And then it's coming less surprise to me why we are so reliant on it and why sort of demand is about half of we actually get out of the donors. So we have some guidance to support our project and our initiatives. So let's have a look what the current guidance is. So in 2019, NBCT recommended appropriate use of group OD negative red cells, and they stated that D negative adult males or females greater than 50 years old with not known anti-D antibodies undergoing major hemorrhage and requiring significant number of units greater than 8 may receive OD positive red cells. So this guidance came out sort of at the same time when we were looking into implementing this initiative. And I'm not criticizing the guidance at all, but our hospital transfusion team was trying to sort of understand it, and then it's came with thinking like, okay, so how do we know the patient will require 8 units? At what point exactly do we switch to OD positive red cells? So we felt it wasn't very clear, and also our algorithm actually reflects that guidance when we didn't knew how to use it when we were implementing. You will see on the next slide. In 2020, and I really like this, NBCT published appropriate specification for emergency red cells that clearly says that males and women greater than 51 years old we need to use OD positive red cells, or is recommended to use OD positive red cells in massive hemorrhage situation. And then this initiative is also supported by BSH guideline for hematological management of massive hemorrhage, and they say that group OD negative and KEL negative red cells should be prioritized for females of childbearing potential and the patients whose gender is unknown. So there's a lot of guidance to support what we are doing. So let's have a look at the actual project we were doing in Royal Derby Hospital. So it was 2019 when we started to look in implementing of this initiative. So there was the NBCT guidance and we've done some audits. So to help us with decision, we conducted a local audit of all emergency blood use. So we'd look at the data from January to October 2019. We have looked at all patients who received emergency blood. So we were using, we don't have an electronic tracking system or anything else. Everything is on the paper currently. So we were looking at every single emergency blood collection sheet to identify this patient. And then we sort of categorized them into 2 different groups. One group was adult males and females greater than 50, and the other group was children and female less than 50. And then when we sort of look at the data, adults, we audit show that total we had transfused 154 O negative red cells during that time. 99 of these units were transfused to adult males or females greater than 50 years of age. That means 64% of total emergency red cells possibly could have been OD positive if we were to implement this project. So that was quite good data, which supported that why we need to implement this. So we presented our findings from this audit with all the supportive evidence and materials to our hospital transfusion committee, and without any major resistances or anything else, we had a green light for the project, and we could start implementation. So this is the algorithm we put together, and we trained the lab staff on it. This is was your decision tree, how you decide if you are working as a scientist in the lab, what type of blood you're going to give to patients. So if we had a patient who had been bleeding and we had no sample available, if they were child or female less than 50 years old, they would get O D negative blood. If they were adult male or female greater than 50, they would have O positive units issued straight away. If we had a sample, but there was no history, and I think this was because of that 2019 guidance, that we wanted to make sure we don't give O positive blood straight away, we would do rapid group. So we would establish RHD type, and then depending on the results, we took 3 possible routes. So if the patient was type as to be D negative, we issued emergency ONEGs. We issued up to 4 units of emergency ONEG, and then if more units were required, if there was a female greater than 50 or adult male, we would change at this stage to O positive. So that was sort of implementing that part if they need a lot of blood greater than 8, but we decided 4 was enough, and then we giving O positive. If patient was type as OD positive, if they were female greater than 50 or male adult male, we would issue O positive straight away. If we were female less than 50 or children, we would still issue emergency ONEG. Then if we had a sample and a historical blood group, we would do rapid blood group and we would issue type-specific blood. So this was the initial algorithm that we used for implementing O positive red cells in emergency. So there was a lot of teamwork for implementation. It was quite a large scale project, and our hospital transfusion team was working in collaboration with all the clinical areas. And there were some critical steps for implementation. So first one was to raise and actually complete laboratory change control process, including risk assessment. So it's really good, this CCRs. I mean, yes, I'm scientist in background, so I kind of like it, but it's good place where we can keep all the evidence, so we know actually, yes, we are ready to go live, and then we also can look back if something has been missed or it has been working and everything else. And we had to train every member of staff who was working in blood bank. AP were trained, so we have associate practitioners working in blood bank. They had a training for awareness, so they are aware of the change, and then BMSs had a full training and competency assessment. Part of the training was to actually present the evidence, because we felt like training is not too complicated. It's not the rocket science. You've got the algorithm and you're going to give them O pos. But what we want BMS is to understand why we're doing it and actually understand that it's quite safe to give this, so they are confident when they have to make that decision. We also done a competency assessment for every BMS, and that was mostly involved around a lot of different emergency scenarios, a lot of different categories of the patient requiring emergency blood. Then we had to train all the clinical staff. So what we've done, it was quite thorough training with high user areas. That would be A&E, operating theatres or ICU. And then with the rest of the clinical teams, we communicate this change via the transfusion links. So we have a trained trainers in each area, so we communicate via them, and also through the hospital intranet, so that everybody was aware of the change. And then last part was to incorporate the use of O positive red cells into trust blood transfusion induction theory, so we can move that forward for the new staff when they come into work in our hospital. Okay, so part of the implementation was actually to make it obvious that we are having two different emergency red cells and to be able to distinguish them. So we produced the labels, simple luggage labels, which clearly indicate which one is which. And for O positive, we actually put on the label who's that for, so the clinical area can double check if the blood bank scientist actually selected correct blood for them. We sort of ensure that both different blood groups have a separate storage area in the fridge as far as apart as possible. And then also O positive red cells are only prepared by BMS on request. So these are not available for clinical area. Just walk in and select OD positive red cells. It's the BMS in blood bank. If they are pre-warned by the telephone call that they will select appropriate emergency blood. Obviously, there is always O negative red cells available in the satellite in the issue fridge for clinical area to be collected if they don't have a time to speak to blood bank, because we wouldn't want to compromise the patient safety. So that was the plan. That was all set up, and it was mostly quite straightforward process, but there were some struggles and issues surrounding this, as probably every change when we are trying to implement it. So there was some stuff, not only a newbies actually, who were nervous about giving O positive red cells to patients with the unknown blood group. They were worried that the patient is presenting in A&E, they might have an anti-D and it will cause severe transfusion reactions or any other harm. There was some staff who were still sort of keep giving O negative red cells, not very often, but then we sort of, if we could identify who was on duty, who actually made that decision. So we were just trying to explain into them what is the barrier and how can we support you. And we haven't seen that happening very often. And then staff were worried that they will actually select the wrong blood in a hurry. It's all in the fridge. You have to make a conscious decision to take O neg or O positive. So that was the other worry. And then we had a few occasions where clinicians I put insisted, but when they sort of ring activate massive hemorrhage and you tell them that the patient's going to have O positive red cells, they were not that impressed with it, or didn't probably know that is happening, because as much as we try to communicate through the links, through the HTC, through the intranet, I'm sure that the message didn't go straight to everybody straight away. So this usually was resolved if there was a time to have a quick chat on the phone, then we just explain what we're doing and then they were fine with it. If there was no time, we purely give O negative red cells. And then the worry of picking the wrong blood has actually happened, and we had given O positive red cells to young female. So there was a young female presented in A&E who was bleeding. There was request for 2 units of red cells for urgent transfusion. So because we didn't have a sample in blood bank, the emergency blood was indicated. BMS was about to prepare O neg, so they fully understand it's a female of childbearing age. They need O neg, and instead of giving O neg, they selected OD positive red cells, and they were collected to a clinical area. 1 unit was transfused, and second one was recalled after BMS identified the error. They only identified the error when they were going to replace the O negative red cells. They came to replace them and they realized there are still 2 O negs in the fridge. So when we haven't been looking at the lab investigation, outcome was that the BMS checked the patient on the lab system and they've seen that the group was D positive. They fully understood that they still needed O negative because of the age, but they sort of, during the preparation of the transport box and the blood, they got distracted. So there was somebody was buzzing on the door. In this stage, they didn't know it's the clinical area who actually collecting blood, but it was the clinical staff who needed to access into issue fridge room. So they went out, led this clinical staff into issue fridge room. When they returned back to blood bank, they selected 2 O positive units. They were taken to clinical area, and obviously one of them was transfused. When they were sort of doing their reflection and everything, they realized that they were distracted. On the emergency collection sheet, there was no RHD blood groups of the unit actually written down, and they may have not checked the luggage label because it was underneath the compatibility label. Patient who received this 1 unit was tested for K antigen and they were KEL negative, and the unit they had transfused was KEL positive. So the patient was informed of the harm, and the letter was sent to a GP to ask for follow-up sample to test for alloimmunization with anti-KEL, but we had not received a sample, so we can't say if we actually caused the alloimmunization or not. So let's have a look at the result. So we are now 3 years from the implementation. So in 2020, total number of emergency red cell transfused was 219, and from that 83 units were O negative and 136 units O positive. In 21, the use of emergency red cells increased slightly. Total units transfused was 248. Out of that, 105 OD negative and 143 D positive. And in 2022, the use of emergency blood increased even further, up to 296 units, and there was 93 O negative and 203 D positive units transfused. So in summary, between January 2020 and December 2022, we have given 763 emergency units, and 60% of these were D positive, which accounts for 482 of D negative units saved by implementing of this project and patient blood management initiative. So can we develop further? Yes, we can. We always can. But in our case, yes, because as I mentioned, we currently don't have any OD positive units in the satellite or in the issue fridge. It's because we don't utilize any electronic tracking system, so we would purely rely on clinical staff to come to issue fridge room and select correct units depending on the patient demographics. And we feel that would be too risky. So currently in our issue fridge is only 2 units of ONEGs, which are being sometimes picked for patients who are adult males or who are females greater than 51 years old. So there could be some saving of O negative as well. But then also, when we were last year in 2022, we were implementing new lab system. So at that time of implementation, the type specific issue of the blood was disabled. That meant if we had a patient who had the historical samples, but the second sample or the current sample process haven't finished, they are getting O emergency red cells. So I feel like if and when we'll bring this type specific use, as it's also recommended nationally, that we could save some more O negative red cells. So thank you for listening. I would just like to thanks to my hospital transfusion colleagues who were involved in implementation of this project, and also NHS BT and SHOT for the use of their images.